Good evening, distinguished speakers, respected moderator, and dear participants. On behalf of the organizing committee, it is my pleasure to welcome you to this webinar session held as a pre-event of Indonesian Congenital Heart Disease 2026. Today's Indonesian Congenital Heart Disease pre-event webinar with the topic Zero Fluoroscopy ASD Device Closure, Why Change When We Are Already Comfortable? My name is Selena, and I will be your host for this evening. We are honored to have esteemed experts joining us today to share their insights on advancing interventional cardiology practices, particularly in reducing fluoroscopy use while maintaining procedural precision. Next, allow me to share some promotional announcement in Indonesian. Sebelum acara dimulai, saya ingin mengingatkan kembali beberapa hal menarik mengenai konferensi yang akan datang. Tahun ini, Indonesian Congenital Heart Disease akan diselenggarakan secara offline bersama dengan the 5th Asian Pacific Society of Adult Congenital Heart Disease di Bali, Indonesia. Acara ini akan dilaksanakan pada tanggal 17 hingga 20 Juni 2026 di The Trans Resorts Bali. Akan ada berbagai sesi ilmiah yang menarik, termasuk 7 workshop, 9 simposium, dan 1 plenary session. Nah, kita juga ada kabar baik untuk seluruh peserta. Dalam rangka memperingati Hari Pendidikan Nasional hari ini, kami akan memberikan 10% diskon untuk seluruh scientific session. Promo ini hanya berlaku untuk hari ini, jadi jangan lupa untuk segera registrasi melalui website kami dengan menggunakan kode promo Education Day 10. Dan juga spesial hanya untuk peserta yang hadir pada webinar pada hari ini, setiap peserta yang share sesi ini di Instagram Story dan juga men-tag akun kami di @kardiologipediatrik dan @InaCHD 2026 akan mendapatkan diskon 25%. Dan juga bagi satu pemenang dari Instagram Story terbaik akan mendapatkan 1 tiket simposium gratis. Selain itu, jangan lupa untuk bergabung untuk pre-event webinar kami berikutnya yang berkolaborasi dengan MedSense pada tanggal 8 Mei 2026 ini. Pada webinar selanjutnya, kita akan membahas topik Hidden Congenital Heart Disease in Daily Practice. Webinar ini dapat diikuti secara gratis dan juga telah kami siapkan 2 tiket simposium gratis untuk peserta yang beruntung. Jadi jangan sampai ketinggalan juga karena topiknya tentu akan sangat menarik. Terakhir, masih ada berbagai promo dan giveaway menarik lainnya yang kami siapkan. Salah satunya adalah weekly Instagram quiz dengan kesempatan memenangkan 1 tingkat simposium gratis setiap minggunya. Jadi jangan lupa untuk pantau terus Instagram kami di @kardiologipediatrik dan @InaCHD 2026 untuk mendapatkan update terbaru. Now we're on to the main session. Today's session will consist of 3 presentations which all will be moderated. Speakers are kindly asked to share their screen prior to presenting. Without further ado, let us begin today's session. To guide us today, it is now my pleasure to invite our respected moderator, Ana Ulfa Rahayu, Medical Doctor. Ana Ulfa Rahayu, Medical Doctor, is a senior consultant in pediatric cardiology and a distinguished leader in cardiovascular medicine in Indonesia, with extensive contributions in clinical practice, education, and organizational leadership. She will be guiding throughout the entire session, including the presentation, panel discussions, and also the Q&A. Without further ado, I would like to hand over the session to our moderator. The floor is yours, Doctor.
Thank you very much. Dear colleagues, good evening. Welcome to the pre-event webinar of the 6th Indonesian Congenital Heart Disease in conjunction with the 5th Asia Pacific Adult Congenital Heart Disease, which will be held in 17 to 20 June 2026 in Trans Resort Hotel Bali. So make sure that you will attend it. Our topic tonight will be about zero fluoroscopy ASD device closure. Why change when we are already comfortable? Thank you for Dr. Monique Francisca Roti from Manado, North Sulawesi, for your hard work in organizing this webinar. There will be 3 prominent speakers. First is our guest from the Philippine Heart Center, Dr. Jen Antonia Golfo Piraglia, And then there will be also two prominent speakers from our country, Dr. Aryo Suryo Kunchoro and Dr. Radityo Prakoso. Dear colleagues, ASD is the second most common congenital heart disease, makes up to about 10 to 15% of congenital heart disease, with the incidence reported at around 2.9 per thousand live births. Patients with a small ASD are often asymptomatic and they are not diagnosed until adulthood. In the indication for ASD closer include symptoms or evidence of right ventricle volume overload in the absence of irreversible pulmonary hypertension. Transcatheter closure of secundum ASD using a combination of fluoroscopy and transesophageal echo has been the gold standard since the introduction of this procedure in 1970s. Recently, there have been increasing effort to reduce the exposure of ionizing radiation in the cardiac cath lab, both for patients and staff. The significant enhancement of through 2D and 3D echo, transthoracic and transesophageal echocardiography for defect anatomy, size and rims, device and material visualization have reduced the dependency on fluoroscopy. It was Peter Ewert from the German Heart Institute Berlin who introduced zero fluoroscopy for ASD device closure about 25 years ago. Many experts from income countries find this approach cumbersome, but for us in low medium income country, it's a breakthrough cost reduction and to promote patient and staff safety. In this case, the role of Marcel is crucial. In the next 20 minutes, Dr. Aryo Suryo Kunchoro from he is a senior expert in echocardiography in the National Cardiovascular Center Harapan Kita Jakarta will tell us the tip and trick to become a good muscle for free fluoroscopy in ASD closure. I will give 20 minutes to Dr. Aryo to present his presentation. Please.
Yes, thank you, Trana. Good evening to everyone. So first of all, I'd like to thank all the committee for inviting me to be part of this important session and be part of the InaCHD's annual meeting. Is an honor for me. So I'm happy to share about the imaging for the zero fluoroscopy procedures, which the focus of my talk for the next 20 minutes. Okay. So can everybody see my slides? I hope my slides is already clear enough. Okay, so I think I would like to start from this slide. I think the slide is whenever I give a presentation about the zero fluoroscopy, this is the first slide that I show, because I think this is very important to show that it is started from 2018. There's the pediatric cardiology department from Harapan Kita started or initiated the procedures of the zero fluoroscopy, and since then I think it's hundreds of cases has been done every year, and we are from the Eco Lab. It's proud to be part of these procedures, and we feel like a lot of things, a lot of new skills and knowledge that we learn, and we feel that we grow together in this, and then that's therefore we feel grateful and we feel honored to be in this part of this process, and therefore I think since we are going to talk a lot about the use of the echo and in terms of this zero fluoroscopy technique. So in terms of echo, either it is a transthoracic echo or transesophageal echo, we need to understand that the basic is the ultrasound, and which we as the doctors, the physician involved in these procedures, we have to understand about the ultrasound physics, basic physics of the ultrasound. So we have to again remember that the whenever whatever object that we're going to see, which is going to be more clear for us to visualize when we see the more reflective object. Of course, when an object is not considered reflective, so we will not be able to see the object clearly. So the object which is perpendicular to the source or the transducer will be more clear, which is very important whenever we wanted to look at the septum, when we wanted to look at the wall, when we wanted to look at the wire or catheter. Of course, it will be more clear whenever the position of the catheter or wire it is perpendicular to the transducer. And the law of frame rate also is very important. The bigger the visual field, the lower the frame rate. And this is important whenever we deal with patients with tachycardia, especially with those with pediatric, also probably in the general anesthesia, but sometimes we deal with those with persistent tachycardia, and then we have to understand that the frame rate will be need to be higher. The small or thin object will be difficult to visualize, and that is a part of the art of how we visualize the object. For us to look at to show to the interventionist operator, for them to be able to locate the object and then proceed with the procedures. The resolution also important, meaning that this is clarity of the object, and the resolution is much better in smaller field. So when you feel like the views of the images is not that clear enough, and to make it more sharp, and then you can solve that if you make the field a bit smaller. Gain and brightness balance is important, so not too bright but not too dark. So I like to be a bit brighter in terms to for us to see the catheter or the wire or small objects to show to the interventionist or the operator. So the higher frame rate is gained from a lower depth. So depth is also important, and lower heart rate and higher frequency probe. So in terms of all of this knowledge about the ultrasound, I think what I mentioned here is actually the basic uh, physics of the ultrasound, which we have to understand whenever we do the procedures using the echocardiography. Okay. So I think we compare TTE and TEE. I think we understand that TTE or transthoracic echo is more familiar to use, and of course sometimes we don't have any other choice to do TTE rather than TEE, because we do the procedures on the small children, and then shunt. In terms of shunt, is usually shunt flow is clear and easy to measure, especially we are talking about VSD, PDA, or ASD. But the drawback will be artifact may be there, especially to those objects which is far away from the source of the far away from the source of the ultrasound, and we have to put the probe at the sterile area, so as our working views. So usually on the subxiphoid, so we have to be careful, especially when we deal with very small children, and then we have to move not that very prominent. And subxiphoid view is superior for smaller children. And to look at the aortic abdominalis, IVC, SVC, short axis views, main pulmonary artery and heart chambers, we can see clearly from the subxiphoid view. And also if we wanted to look at the interatrial septum or interventricular septums and also valves, we can also do from subxiphoid views. From TEE, on the other hand, it actually can provide clearer images compared to transthoracic, and it's less artifact and clearer with the great artery structures. And the devices are easier to visualize compared to when we use a transthoracic echo probe. And superior in most cases, as I mentioned already. And 3D modalities, if you have a TE with 3D, is it's important addition to the TE. If it's available, it's going to be very helpful in terms of device closure procedures. And in this case, whenever we are talking about the ASD shunt, the which is with the form was like a hole like shape. I think with the 3D we are able to look at the unfast view, and we are able to look at the the real dimension of the shunt. So we were able to look at the size, which is more accurate if you're using 3D. So if we start to do the zero floor technique, the basic understanding principles will be visualization of objects during the procedures. So we are going to deal a lot with the tube like structures like wire or catheter. So we need to understand, and we have to see the complete visualization of body to the tip of the tube-like structures. And I think this is very important to look at the end or the tip of the structures where it is heading. So we don't want to see let's say we don't want to see the wire or structures go to the appendix, so we have to make sure that tip is there. So again, that's our job to make sure that it's not in the area which we wanted to avoid, and that's the art of how we actually need to show the objects to the operator. So we need to identify the area which need to be avoided, as I mentioned already, is such as arterial appendage, and whenever we do a procedures like ASD closure, and the thorough evaluation before procedures is also very important. Like we look at the pericardial effusion before the procedures, and then Kyrie networks, pulse function, and also ventricle functions before the procedures. So we'll be able to evaluate after the procedures is done. And these are just the pictures. When you look at some objects, which is quite clear. If you look at the TE, these are the examples of when we're using TE. And I think we can see here. This is that the object for the device is quite clear when we look at when we use a TE from some views. So on the questions, probably when to use or not to use TE. So maybe you would like to choose TTE rather than TE. So the patient factors, definitely age of patients. And then when the patient is too small and we cannot use TE, comorbidity of patients also need to be put into account. And the preference of patient, maybe, we don't know. And the morphology of the defect. Some defect, maybe we rather use TT than rather use TE. And the interventionalists probably to prefer more to look at the TTE rather than TE. And also, of course, the echocardiographer itself maybe is not really confident with using TE. And also, and factors from the institutions or from the hospitals, availability of the device, availability of anesthesiologists and other team member, and probably related to hospital procedural volume. So there's also factors which might affect whether you want to choose TE or PTE. So, but nowadays we have a mini 3D TE, which we can use from the children with a body weight as low as 5 kilos. So it is very helpful and useful when we wanted to do procedures using TE 3D into small children. In the era of minimal non-zero fluoroscopy, so there are things that we have to remember for peri-procedural evaluations. We not just decide the device size. We just need to also to look at to choose which device type and size which is suitable, and also during the procedures, of course, guide catheter and wire, and also crossing process of the catheter, wire, and also sheath, delivery sheath during the procedures is also very important. And this is, I think, part of the very important role of this imaging during the zero fluoroscopy procedures. And again, of course, and we are able to evaluate immediate results after the procedure is done. And this is the right side is actually is the same, but we have to look at those with challenging defects. So we can be very precise about the decision, and we can do a communication discussion with the operator about the strategy and the end result which we expected. And of course, when we're talking about the using echo, still has to be some certain training for to be able to be able to do the guiding procedures in the interventional transcatheter interventional procedures, and based on this is a guideline of American. If you look at the volume and numbers here is I think it's yeah, it's a standard of when you wanted to start the program, and you need to evaluate yourself whether you are competent enough to do to start the zero fluoroscopy and to be the marshaller of these procedures. And I think skill is very important, because whenever you do the zero fluoroscopy, so I tend to see that probe is just like our playground. So we have to understand the how to maneuver anti-flexion, retroflexion, clockwise, counterclockwise, and so on. So and then most of the time we have to do a lot of maneuver at one time. So the thing is, the point is that we have to whatever it takes to show the object which we intended to look at more clear. So and then the operator able to decide what to do or what next, or when to stop or when to proceed. So based on our images. So I would so our my next session on this talk is just a little bit of about the imaging and common device closures, ESD, PDA, and FASD. I hope my time is okay. So for let me start from the imaging for the ASD, either with the TTE or with the TE. TTE, of course, is a routine modality. We use it to look at the ASD type, but if you wanted to look at the ASD more clear, you have to do TE. We know that it's a superior modality for the diagnosis, and in terms of the device decision, for the device closure decision, of course, we have to proceed to the TE. And don't forget, and we have to also to evaluate other structures such as valves and also the cardiac function. And also let's not forget to look at is there any pericardial effusion before the procedures, so we can be clear that there is no complication of pericardial effusion during the procedures. So the minus of the TE, of course, is semi-invasive, and some inferior rims may be difficult to identify in some cases, in some challenging cases. So, but it needs some special, trick to look at the inferior rim sometimes. Okay, so this is steps when to do in the ESD. So whenever we decided to proceed to the zero fluoroscopy for ESD procedures, so we have to get the catheter wire from IVC to SVC, and the track the wire catheter to left atrium, and we need to inform the operator that the wire catheter is going to left upper pulmonary vein or any other PV which is intended. And distinguish between LAA and warfarin reach is very important, because LAA is a area which we want to avoid. Make sure that whatever the object which we intended to do the PV is inside the PV, and we need to sometimes do several flush procedure with the saline. And tips of this are to evaluate the body of catheter, adjust angle to view long axis or off the catheter wire. So tips of the catheter wire may be difficult to show, but track trajectory with angulation and probe rotation technique. And this has to be done in a very short time, and therefore skill to do this is very important. And then the next step is to get the catheter wire from LA to left upper pulmonary vein, and then of course then the thing that we need to show the delivery sheet and the wire from IVC to crossing the enteroarterial septum to the left upper pulmonary vein. And this is very important procedures because delivery sheet is a big structure, so we don't want the sheet to be in the left atrial appendix. So we need to make sure that this is already in left upper pulmonary vein. So and then the device deployment. Also, this is our working view, usually at the 40 or 40 to 50 degree offshore axis view, whenever we able to see the posterior rim and also the aorta rim. So we are able to track the device moving from the left upper pulmonary vein whenever the operator ready to pull the device slowly from the left upper pulmonary vein, going into the enteroarterial septum and then do the deployment in that area. So we have to make sure that all the rim, especially in this view, number 3 view, that we have to confirm that the posterior rim is already inside the disc, and therefore, and then after that, then we do another evaluation from other angles to make sure that all other rims is already captured by the disc, and then we also have to measure is there any residual shunt or not. So the steps to make sure this rim which is already inside the disc sometimes is tricky. Again, we have to do multiple angle to make sure of this, not just rely on this one angle I think is most important thing. For me, I use more than 2 angles, at least short axis view and also bicarpal view to make sure that all the rim inside are already inside the disc, left atrial disc and right atrium disc. And also, of course, we check again the residual shunt. And then points to remember, I think the most important thing is just to make sure that we have to avoid this area, left atrial appendix. So I think there are plenty of cases when doing the ASD, then there's a perforation of the left atrial appendix and causing the tamponade, and we have to send the patients to the surgeon. So we want to avoid that. We have to make sure that all the sheet and everything else is going into left upper pulmonary vein rather than going to left atrial appendix. And this is also important, early sign of pericardial effusion. We also have to be the first person to identify this and then inform to the operator to check about this. And then we have to probably stop the procedures if we think that this is too dangerous to proceed. So, and the next is VSD and in the era of zero fluoroscopy. And I think the role of echocardiography is not just to detect just to look at the VSD and to look at the also the size of the VSD. We also need to look at whether the VSDs is affected adjacent areas such as tricuspid and aortic valves, RCC, right coronary, right aortic valves, and then we need to also to make sure that whenever we do the procedures, we're able to show the device clearly during the whole procedures. This is also important because or else so we will not be able to guide the procedures completely. So during the procedures of the VSD, so of course during the before the procedures, we need to look at the device. So we need to look at the defect, decide the size of the device, decide the size of the device and the type of the device that we're going to do. And then post deployment, we look at the stability and residual shunt and adjacent structures evaluation and also pericardial effusion. And this is the strategy to look at this device depends on the operator, whether the operator decided to do the retrograde or antegrade approach, and that's going to be the strategy for the echo is a bit different. So the for minimal fluoroscopy, so I think we need to also guide during the device crossing procedures, guide the deployment and also evaluate immediate result. So in terms of interventricular septum crossing. So it's a bit tricky sometimes. It depends on the type of VSD. But the point is that we have to visualize catheter and the wire during the crossing procedures. Sometimes it's difficult, and sometimes we give up and we just do the fluoro instead. So it's quicker sometimes. And also during the device delivery, and also I think it's very important if you use echo, because we are able to look at the piece of the device approaching to the interventricular septum, and then we need to tell the operator when to deploy in the device in the defect. So I probably have some other views to show. So here's when the approach is retrograde, whenever we use a T guided procedures. So we need to visualize the catheter from abdominal aorta to aortic arch. Usually we can do TE, or if you're not able to show the view is not already clear enough, we can change to a transthoracic, of course. And then we need to show the aortic arch and aortic root area clearly to make sure the wire or catheter is crossing that area and going into the left ventricle. And we have to make sure that it's crossing the aorta, going to the left ventricle. And then we have to also detect the position of the catheter or the wire. It is pointing away from the interventricular septums and or already pointing to the interventricular septum. So whenever the operator decided to do the integrate approach, which is I think it's more difficult for us to actually to guide, to be honest. It's a bit tricky, but the point is we have to show the catheter to the RVOT area, to the pulmonary or to the main pulmonary artery, and then we have to guide for this catheter to go into the defect. To be honest, sometimes it's for me sometimes it's too difficult, and I just let the operator change switch to the fluoro instead. So about the deployment, I think whenever we use TE, I think it's quite obvious that using TE is very useful to look at the device during the deployment system. So usually it's quite clear with this views, and we're able to look at the device. We look at the disc. This is a retrograde approach, so we can see that this is deployed from the RV and going into the interventricular septum, and then doing the deployment in that area. And then we can also immediately look at the impact of the device position to the aortic valves, and we can show whether there is any aortic regurgitation or not. So in some difficult cases, we have to do some spatial views. So we cannot just rely on routine views, long axis views. Sometimes we have to go to the deep tricuspid view to look at the some VSD, which is more close to the tricuspid valve and close to the tricuspid inflow. And then we usually are able to look at the 5-chamber views from deep tricuspid view, which is more clear to look at the defect of the VSD from this view. And then we are able to measure the shunt, and then we are able to decide which size of the device that we're going to use. Okay, so I think my time is up. So I just wanted to look to show some procedures which is we do TE for the during the procedures. Yeah, we for this special for this type of VSD, which is close to the tricuspid valve inflow, we usually use this RVT views, deep transcatheter views, and also apical 5-chamber views, and also psoriasis views of tricuspid valve is sometimes useful to look at the position of the device to the tricuspid. And I would go straight to the PDA. This is my last part of my presentation. I think using TE for the PDA device closure is especially very important, and especially when we already have 3D and we can see the shape of the PDA, and we can decide which device that we're going to use. It is more, I think it is more accurate. And I believe so we already see plenty of cases where it's just using a 3D. This is very helpful for us to decide the device which we are going to use. And I think this is just an example of some cases. I know my time is up. Sorry. So I think my last slide here is, I think whenever we do zero fluoroscopy, training is important for us, echocardiographer, and also for interventionists to understand the echo. Ultrasound physics definitely has to be main part of the knowledge for us, and they understand anatomy, imaging, orientation, and tissue landmark in both 2D and 3D point of view. So again, I think it's also very important that we have to have a good understanding between echocardiographer and interventionist. I think that's all from me. Thank you for listening. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Aryo, for your sharing of your experience. It was truly inspiring, and it is very important for the succeed of this procedure. Now we come to the second speaker, that is Dr. Jan Antonio Golfo Villarreal from the Philippine Heart Center. He's an expert in intervention for
Good evening.
congenital heart disease. So I'll give you the time for 20 minutes, Dr. Jan.
Thank you, doctor. Do you hear? Can you hear me?
Yes,
Yes,
absolutely.
but I haven't seen your slide yet.
Yeah, I'll share my slide. Can you see now the slide?
Yes, perfect. Can you make it a slideshow, please? Yeah.
Oh, sorry. Is it a
Yes.
slide? Okay. Oh, wait. Does my slide shows?
Yes. Yes, you can continue.
Okay. Good evening, colleagues. It is a privilege to talk in this pre-event webinar. My title is Going for the Moonshot with Zero Fluoroscopy. So, in behalf of the Philippine Heart Center, I would like to extend my heartfelt gratitude to the organizing committee of the Indonesia Congenital Heart Disease and the Asia Pacific Society of Adult Congenital Heart Disease 2026. I would also like to thank Dr. Radityo and Dr. Concoro for gracing our ASD Masterclass last March 2026 and giving this as a platform to share our experience and early outcomes in zero fluoroscopy in ASD device closure.
Sorry, can you make it a slideshow, please? This is too small.
Uh, so the
Yes.
objective, okay, is it okay?
Yeah.
Okay, thank you. The objective of this talk is to give a background of zero fluoroscopy and present cases of ASD closed percutaneously without fluoro and present our early outcome of zero ASD device closure at Philippine Heart Center. So, why zero fluoroscopy? Imagine no radiation for the whole procedure, and definitely this will ensue safety of our pediatric and even adult patients, the safety of the operator and the team, specifically our cath lab personnel. So, in one study by Ewert and Berger, they did a transcatheter closure of ASD without fluoro on both ASD secundum and patent foramen ovale. The total number of the subject were 22 patients. The success rate was 86%, and 14% failure rate was due to the following reasons. There was presence of atrial septal aneurysm, the LADs configured incompletely, and handling of new devices. So in this study, they also noted that there was no significant difference in the procedure time and complication. So in conclusion, the transcatheter closure of ASD can be safely performed under echo guidance without fluoro. Uh, in the transesophageal group, they noted that the non-fluoro, the procedure time was significantly shorter and with less intraprocedural events and complication. So here are some of the cases we did in our center for zero fluoroscopy technique in ASD closure. So an 8-year-old female with recurrent bout of cough who weighs slowly and noted with grade 3 over 6 systolic ejection murmur with fixed and widely split P2, which is consistent with ASD secundum. So in X-ray, you can note that there is a markedly enlarged heart with increased pulmonary vascular markings, and the CT ratio is 0.6. The upliftment of the apex is significantly of the RV enlargement, and the MPA is very prominent. ECG shows sinus rhythm with normal axis and normal limits. Transthoracic echo showed measuring of the defect as from 8 to 13 millimeter with left to right shunting and a gradient of 6 millimeter mercury. Transesophageal showed four chamber view revealed ASD measuring 7 to 9 millimeter with left to right. Anterior and superior rims were basically sufficient. And by transesophageal echo, the ASD revealed about 7 to 10 with left to right shunting with adequate or sufficient SBC and IBC rim. This slide shows that the bicaval view or 95-degree angulation noted with sufficient SBC and IBC rim. Then we proceed to a step-by-step of closing the ASD using the non-fluoro, making sure that the patient is always sedated or under general anesthesia, making sure that the tip of the left shoulder to the inguinal or access is determined with the maximum length of the catheter to be inserted. And once the length is determined, we can now insert the multipurpose catheter. So once we insert the catheter to the defect with the straight wire, the echocardiographer will angulate it to a modified retroaortic view in order for the operator to see the direction of the wire and the catheter going through the left upper pulmonary vein, as was seen in this view. It is of great importance that the echo and the operator communicate to maximize the view and the movement of the catheter. Once the wire is secured at the left upper pulmonary vein, we may exchange the catheter with the delivery sheet and an appropriate device, which may vary from French 7 to French 14, the delivery sheet, depending on the measurement of the ASD. In this slide shows that the ASD used was a Seraflex occluder 12 millimeter which is in place. The LADs is at the left atrium and the RADs is at the right atrium. So once the position is secured, our echocardiographer will make sure that there were no leaks at the sides of the devices. The only leak that is admissible should be within the device. And before releasing the device from the cable, the device will be checked on three important orthogonal view or angles or views: the four chamber, the retroaortic, and the bicaval view. So in our study in 2019, the comparison of the outcome of ASD closure with or without fluoroscopy, there are a total of 48 patients. 70% or 34 patients underwent closure under fluoro NTE guidance, while the remaining 14 or 30% underwent only TEE. So the outcome measures were based on the following: the residual shunt, the procedural time, the embolization or complication, and the length of hospitalization. So these data showed our study population is between the age of 10 to 16 years old, with a mean age of 12 to 13. Both groups are predominantly female with a mean weight of between 40 to 43 kilograms. The defect size ranges from 10 to 18 millimeter with a normal pulmonary artery pressure. So the duration of the procedure noted is to be much longer in the non-fluoro group, which may be secondary to the operator's initial experience as compared from the international study. The same group outcome noted to have an embolization complication for both groups, but this is comparable to both local and international studies. The length of stay noted to be no significant difference in both study groups. So in conclusion, the zero ASD device closure is a safe and efficient method that has an equivalent outcome with the conventional way of transesophageal echo and fluoro-guided procedure. So we noted that there should be an excellent transesophageal views and availability of easy to manipulate devices that these may validate the closure of ASD without the routine use of the fluoroscopy. So I would just like also to share some of the interesting case. This is a 4-year-old male with stable vital signs with continuous grade murmur 4/6 at the left upper sternal border, consistent with patent ductus arteriosus. The chest X-ray showed prominent left ventricle with sinus rhythm by ECG and findings of a PDA size 4 millimeter at the pulmonic side and 6 millimeter at the aortic side. There was a continuous Doppler signal with a maximum gradient signal of 118 millimeter mercury. The PAN technique follows a standardized three-step flow. First, the operator should establish a vascular access. For example, if you're wanting an ASD closure, femoral vein access should be preferred, whereas the femoral artery may be chosen for BSD and PDA closure. Second, the operator should use the working length or the marking method to measure the distance in vitro and mark it on the catheter and guide wire, confirming the precise catheter guide wire insertion depth. Third, after confirming the location of the affected areas by using the effective echo view, an occluder can be released or implanted. This case was closed by an MFO 10-8 via a retrograde approach. Another interesting case of non-fluoro closure done just last March 2026 at the ASD Masterclass by Dr. Radityo Procosa and Dr. Concoro, closed by some of the team. The percutaneous closure of ASD using zero fluoro technique at 19 years old female with signs of easy fatigability and episode of difficulty of breathing. Pertinent PE revealed right ventricular heave with grade 3/6 systolic ejection murmur with accentuated P2 and a fixed split consistent with ASD secundum. The chest X-ray findings revealed cardiomegaly with right ventricular hypertrophy and an increased pulmonary vascularity. The ECG revealed sinus rhythm with RSR pattern noted on the V1, V3R, V4R, with a tall R in the precordial leads, which is indicative of RVH. The TEE views revealed ASD 1.9 to 3.0 cm with adequate mitral rim of 7 millimeter. The SVC rim was also adequate with measurement of 1 centimeter, while the IVC is insufficient, measuring about less than 3 millimeter, and the aortic read is about 5 millimeter. Bicable view shows at 90 to 110, good SVC rim, but with minimal IVC rim. There is a prominent coronary sinus on short axis, prominent band connecting to the aortic rim, and a somewhat malaligned septum. The bicable view at 90 to 100 showing good SVC rim and minimal IVC. So based on the measurement, it is an oval-shaped defect with minimal IVC rim and somewhat malaligned. So the team, they decided to do a non-fluoro technique with balloon-assisted. The size of the ASD or occluder was decided to be a 34 millimeter cell occluder. So with the aid of transesophageal, the catheter was advanced to the IVC, to the RNASD, and to the LA pulmonary vein. 2 wires were advanced to the LA from the balloon and the delivery sheet. Then French 14 delivery sheet was advanced first and seen at the pulmonary vein. So in 4-chamber view, the device was deployed at the left atrium, carefully positioning at the interatrial with balloon-assisted technique. Once the device sits right into the interatrial defect, the balloon was slowly deflated and retracted slowly. So LifeTech Serra 34 millimeter occluder was eventually released, but noted with complete heart block. The patient was referred to our electrophysiologist and suggested retrieval or removal and possible change to a smaller size device. But the team decided to treat conservatively and start with an IV methylprednisolone for 72 hours and shifted to oral steroids for more than a week. As you can see, the patient's ECG converted after 9 days of steroids. So prior to the discharge, the EPS decided to do a 24 Holter prior to the discharge. It was basically predominantly sinus. There were no significant sinus pauses, but there were occasional or intermittent second degree or high degree AV block with occasional PAC in singles. So we monitored the patients regularly. So this is the 3-week post-procedure ECG, which is, as you can see, shows a regular sinus rhythm with P waves present before each QRS complex and indicating a good atrial activity, and a QRS complex appear narrow, suggesting a normal ventricular conduction. The T wave follows appropriately. So thank you very much for listening.
Thank you, Dr. Jen, for sharing your experience in a Philippine Heart Center. I think as Asian members, I think we face a similar burden in facing congenital heart disease problem, and it's interesting to discuss it later. The third speaker will be Dr. Raditya Prakoso. Yeah, will share with us his experience in these procedures. And I would like to remind you that there will be a panel discussion, and the panelist is Dr. Yufi Kurniawati and Dr. Siska Siagian, both senior staff in the National Cardiovascular Center Harapan Kita. Dr. Aditya, your time is 20 minutes, please.
Yeah, thank you, Dr. Anna. First of all, I would like to thank the organizing committee that allowed me to share about is the limit to zero fluoroscopy. How do we tackle challenging defects with complex anatomy? Thank you also, Dr. Anna, for the introduction. Thank you for my friend, Dr. Jean Villarreal, that being able to share and also to discuss the experience of Philippine Heart Center. And actually your last case is challenging. Yeah, I'm texting with Dr. Kunchoro. You know, is it will be happen or not about the conversion of the complete heart block? And Alhamdulillah, thanks to God, then the patient can be converted into the sinus rhythm. Thank you, Dr. Villarreal. This is my disclosure. So classically, we use a combination of a fluoroscopy and echo guidance, as you see all over the world. But 2019, when Dr. Siang Bing Pan came to Indonesia, introduced me a new breakthrough in congenital heart disease intervention about the zero fluoroscopy. What people thought at that time, fear is impossible. But nowadays, fluoroscopy is only used if operator or marshaller could not visualize the defect or pressures. But as our echocardiographers can now produce good images, the use of fluoroscopy have been left behind. What happened now to those who are constantly exposed to radiation? You can see the operators, circulating nurse, and also the marshaller are exposed to the highest degree of radiation. But is this approach applicable for a complex defect? Actually, it may be more reliable as we can directly observe the intracardiac structure through echo. This is our publication showed the feasibility of performing zero fluoroscopy ASD closure even in the complex cases. Zero fluoroscopy ASD closure in our center, and 2 procedures were guided in TTE, and 99% cases using both TTE and TE. The implantation successful rate is 98.9% in simple cases and 97.1% in complex cases with a P less than 0.001. In fact, zero fluoroscopy ASD closure has been performed across Indonesia, starting from Medan to Manado City, and is still growing, and we are expecting more center can do the zero fluoroscopy technique. And we have achieved this is 519 ASD closure since 14 July of 2018. PSC closure 310, PD closure 120, and PFO closure 35 cases, and total nearly 1,000 fluoroscopy, zero fluoroscopy defect closure in National Cardiac Center Harapan Kita. So how do we approach it? First, determine whether the ASD is suitable, challenging, and should not be closed. As Dr. Aryo and Dr. Villarreal mentioned before, the ideal ASD can be closed easily. But how about the complex ASD with the REM deficiency, malalignment septum, multifenestrated, aneurysmal septum, prominent eustachio valve? We still could closure. But if there's no inferior vena cava or deficiency of the inferior vena cava rim, or the defect is too large, you could not close it by zero fluoroscopy, also in with fluoroscopy. So what is considered about the complex secondum ASD? The diameter more than 38%, small children weighing less than 15 kgs. Defects with the deficient rims, complex morphology, reversible pulmonary hypertension, and arrhythmia. So nowadays, this morphological challenge can be closed. Many techniques, but I want to share the most prominent technique is the balloon-assisted technique. This maneuver is often necessary because the LA, the left atrium, is often small, and so the device may tend to prolapse throughout the device. So complete rim of the aortic rim, complete absence of the aortic rim, septal aneurysm, floppy or absent posterior rim, large ASD more than 25 millimeters, and posterior malalignments, change in posterior septal plane on GEs. Please sweep from 0 to 90 degrees. How balloon-assisted technique works. So the principle is to make the ASD smaller. Let's make sure that the LID is deployed in the LA and the IRD is in the right atrium. When to attempt for the balloon-assisted technique? Decide upon agreement between the operator and the marshaller. Usually, we first attempt the conventional technique, but if after several attempts, the procedure deemed to may have cause complications, balloon-assisted technique is considered. However, when facing a large or oval shaped circumference, we prefer to directly perform balloon-assisted technique. So step by step, as Dr. Aryo mentioned before, so we have to identify what's the diameter, what's the deficient rims, and then sizing balloon. Please put the sizing balloon more than 50% of the defect. Device in hourglass shape with either disc in respective atria and waist compressed by inflated balloon. Balloon is deflated and waist expands. The device in good position, snugly holding on the after removal of the balloon, and then device development. So sometimes there's a tricky one when you want to retract the balloon. Usually we use the super stiff wire, and the tip of the super stiff wire is like a curly wire. So please change to the soft hydrophilic wire and then retract the balloon. Otherwise, you can grab the disc or the device, and it may make the devices dislodge. So what is the limitation of balloon-assisted technique? Extra equipment, an extra cost, additional assistance to hold the balloon against the interatrial septum when the main operator is delivering the device. Hemostasis is occasionally challenging and time-consuming. Balloon may interfere with the proper expansion and placement of the ASD device. Withdrawal of the deflated balloon, as I mentioned before, and make the displacement of the device. The balloon has a high profile and blunt tip. Sometimes it's difficult to push the balloon throughout the skin and subcutaneous tissue. So I usually prefer to put the sheath because it can be easily moving the balloon. Other considerations, octopus defect. It is important to recognize that a single defect may mimic multiple defects due to irregular border and extending like tentacles. Such defects can be seen as a multiple additional holes, can be suspected when the large remaining defect surrounded a small additional defect. Spiral defect. So sometimes now we are having quite malaligned septum. So sometimes the operator or the marshaller said double atrial septum. This is not really double, but it's with a different height, so it caused the spiral. Such ASD have associated with a high rate of technical failure. 3D echo assists the understanding in anatomy, and transcatheter closure can be successful if close attention is paid to the morphology of the defect and incorporation of the margins. Multiple defects. If the defect distance is more than 70%, more than 7 millimeters, so we must put a double disc. a double device. So why? Sometimes when we put the device on the large defect, so it will squeeze another defect. So sometimes we need only put one device. Our limitations so far are these ISDs that could not be closed percutaneous. Pulmonary hypertension that showed inoperability on the right heart catheterization, complete absence of an inferior or IVC rim, and the very large ASD. Or to share about our first experience on the zero fluoroscopy technique. At the time, is 26 years old pre-gravid with 26 weeks of gestation. At the time, there's pulmonary hypertension present, so I did the right heart catheterization. The right heart catheterization showed good results, and so we put the device. Multiple defect, this as I mentioned before, so we closed the large ASD, the large defect, and it squeezed the small. Why? I want to share to Dr. Villarreal that we are not allowed to put the multiple defect unless it's self-paid by the patient. This patient, I have put two devices, still with the zero fluoroscopy technique. The spiral ASD, you can see the rims is malaligned here. It seems okay, but it's quite malaligned, so around 8 millimeters. So at the time I put slight big device, so the rims can hug the aortic part. So the result is good. Large ASD with the atrial fibrillation. So I put the balloon assisted technique. Alhamdulillah, it can be closed easily. Minimum posterior rim. So you're gonna see an oval shape, the ASD, and you can see when I put without balloon assisted, the left atrial disc is easily jump to the right atrium. So I put the balloon assisted and making sure that the LADs and the left atrial disc, the right atrial disc also in the right atrium. Once it's good position and we deploy the balloon, and then the result is good. Fenestrated device, some patients have to make some self-fenestration because the device is not easily manufactured with the cases. So device with the fenestration is not all available at the time. So in this case, we put the self-fenestration. And what as big as the fenestration is about 20 to 25% from the all the defect, and results is good. Small neonates, small children is 8 kgs, and I put the sheath on the left atrium. Be careful, do not intend to put to the pulmonary vein because it could not be easily seen by TTE. But now I got the tricks. Now I put the sheath on the SVC, and then carefully retract and put some counterclockwise maneuver. So the take-home message will be: intervention should use echocardiographic guidance whenever possible. With the advent of the percutaneous procedure, we could close even the complex ASD still with zero fluoroscopy way. Balloon-assisted device closure helps to control delivery and device alignment in very large ASD and posterior malalignment of the septum. Thank you very much.
Thank you very much, Dr. Raditya Prakosa, for sharing with us your broad experience in non-fluoroscopy ASD disposal. I'm very proud of you because you are traveling around the country from Sumatra to Papua, sharing your expertise, and also to Philippines. And it makes me amazed also, you are not trained abroad, but in your own country by your experiences. Well, now we come to the panel discussion. I would like to invite both panelists and for the audience who will give a comment or raise question, you can write it in the Q&A box. But I'll give the opportunity first to Dr. Yofi Kurniawati. Yeah, Dr. Yofi, are you ready?
Yes, Dr. Anna. Thank you. Okay. Thank you, Dr. Anna. Good afternoon to Dr. Jan. And I think I would ask Dr. Aryo or ask for his opinion about the 3D TEE in intervention. I think we already use it a lot as at in our CAT lab for 3D TE in closing in device closure. Do you think what's your opinion about this? I mean, what the added value can we get from using the 3D TEE for intervention? Is there any because I find it very helpful for using 3D TE in seeing characteristic of the the defect. And that's the first. And the second one is about using microprobe for microprobe TE. It can be used until 90 kilos, you said, yeah. But for me, I'm not very comfortable using the probe for the adult because I don't know. There's not very stable. It's sometimes it moves easily when you did it rotate easily, you know. So sometimes I don't see the good view and it cannot the position of the probe to the the wall, the posterior wall it's not good, I think. So I'm not I don't think I like to use the microprobe for adult. That's my question for Dr. Aryo.
Yeah, thank you. Okay. So
Yes.
thank you, Dr. Yes, thank you, Dr. Anna. Thank you, Dr. Yofi. I think I think it's one of important questions that for the use of 3D in the terms of ASD procedures. So for me personally, just like what you mentioned, that we are able to look at the characteristic of the defect itself, whether it is rounded, whether it's elliptical. So what we wanted to see is the real diameter of the defect. So if we just only rely on 2D, sometimes it's not that easy to find which the longest diameter and the shortest diameter. So whenever we do 3D, so we're able to look at which part has a longest diameter, which part has the shortest diameter. So for me, and then we use MBR, so multiplane reconstruction, and then we are able to adjust the plane and the area and where the diameter is the longest and the shortest. And then what I do is, and then again refer to the 2D from that specific plane and then measure in that area. So I did that because and I do not measure directly from the 3D reconstruction, because there's depth in there. So we whenever we see the 3D reconstruction volume images, so we have to remember that there's areas which is not at the same plane, or maybe that not at the same depth. So again, I have and this is very important. If we see sometimes some area of the rim sometimes not at the same plane. So some area maybe is different heights. So it could be important if we just confirm to the 2D after we convince after we confirm that we are able to locate which part is the longest and which part is shortest. So that's what I would do. Another thing is 3D is we are able to locate the which part of the area which has the possibility for the malalignment, which is usually dealing with the different heights of the rim next to each other, which is why we call it malalignment. And then we are able to also to measure the heights of those rims. So I suppose that's the use of, I think, the use of the 3D in that area, Dr. Yofi. And then the second question is sorry.
Prof,
Oh, yeah.
Micro.
Oh yeah, mini TE, yes. Of course, this is because this is small, but because the current technology is they are able to generate a clear view for the adult. So basically, that's for the pediatric cases, Dr. Yofi. But the current technology, they are able to use it also in adult. But I use it a lot in adult, and also I had experience to use that also in matter clip cases, and it's just doing fine. But I think it's in
you have to
whenever
yeah,
sorry.
sometimes you have to the probe you have to make a stable of the probe so
Yeah.
it cannot
So you have
move.
to, yeah, it depends of the maybe the size of esophageal, maybe also the position of the oropharynx, maybe, I don't know. But the thing is, you have to make a good attachment to the tissue. And another trick, if you see that because the probe is small, so there are plenty of space for the air in the esophageal. Sometimes it's the the image is not that clear, and then you do the suction, and then usually an image is a bit clearer usually. But again, yeah, I understand that maybe you need to try to another type of mini TE, maybe radiography, and then you might feel the difference.
Is it can be solved with you make the antoflexy of the probe? No,
Sometimes, yeah, because
can
if it's
be
a problem is attachment,
yeah.
and then yeah, you have to do a constant anteflexion to make it attach to the tissue.
Well, I
Yeah.
think I will continue to Dr. Siska Siagian. Yeah. Do you have any comment or question?
Yes, Dr. Anna. Thank you so much, Dr. Anna, for the time and for committee, and also for three of our speakers here. Thank you so much for the sharing, Dr. Aryo, Dr. Jan, and Dr. Radityo. I have some things actually to maybe some confirm and question also for Dr. Aryo. He is my team actually on the same day. So yeah, we actually sometimes face maybe the same problem from a week to another week. So first one, do you have any recommendation, as you already, in my opinion, very expert in this procedure, what is actually the minimal requirement that we have to say to the marshal that want to do this zero fluoroscopy? As Dr. Radityo always said that, why change if we already comfort with the fluoroscopy way? But in my opinion, sometimes it's not easy to start a new thing if we really have comfortable with our previous way in doing the procedure. And then the next question, maybe this is the thing that also I sometimes ask Dr. Aditya when do the intervention. Sometimes it's not easy to see the pulmonary vein if it is not guided by some experts. So what is actually your opinion or your suggestion how to show the good PV and also the alignment of the septum? Sometimes it's not easy to say that this is malalignment or not. Yeah, it is, I think, the two more common problems that I have when doing the intervention, and also the last one for the multiple ASD, how to decide it is the right hole to go. It is the significant big hole, or it is the small one, that sometimes we cannot really decide which one is the big one, which one is small one. And then for Dr. Raditya and Dr. Jan also, first thing that I want to congratulate Dr. Jan also for their team to use this zero fluoroscopy. Can I ask your opinion about this procedure? What do you think? What is your opinion? So can you really do 100% zero fluoroscopy for your team there? Or yeah, for some specific case, we just have to convert to the fluoroscopy classical one. And Dr. Radit, so should we convert for the complex one? That's my question for Dr. Radit. Thank you so much, Dr. Anna.
Thank you. Yes. Dr. Aditya first, yeah. Can you answer Dr. Siska question and
Yeah,
comment?
thank you, Dr. Anna. So, shall we change? Yeah, I think last 2 days I convert the my procedures because the marshal cannot convince me where's the position. So at the time it's very difficult to understand the cases, because there's quite malalignment cases, and then also I don't know, yeah, because the characteristic of the pulmonary vein is not easy to get that. So whenever I put the catheter inside the pulmonary vein, when I change to the the stiff wire, it's changed always, maybe more than 10 times. So at the time when I start to put the right pulmonary vein also, it's changed. It's easily thrown to the right atrium. So at the time, yeah, with my well, I did also in Philippines at that time with Dr. Sean Villarreal, when Dr. Aryo said to me, "Is this have to be converted?" Or the last case is Dr. Villarreal. So at the time, my heart is very hard to decide, is to convert. At the time in Philippines, I still use convince the whole team we have to put with the zero fluoroscopy technique. But in my daily practice, I cannot change, and also the marshal at that time, Dr. Aryo, cannot have some any suggestion also, or what's another maneuver to the when to cross to the pulmonary vein. And so at the time I changed my foot into the fluoroscopy, and you can see the position of the pulmonary vein is not as you saw. So it goes more lower, not at the usual position.
Dr.
Finally,
Aditya,
yeah.
you said that if it's difficult to reach the pulmonary vein, then you can use the SVC procedure, isn't it?
Yes, it is. If the range is good, Dr. Anna. So in the the small child, less than 10 kgs, with the small with the good range, can put the SVC. But in the last case, this is a 30 years old woman with the spiral ASD. So it's malaligned, so it's very difficult to put. And I usually, I seems I'm very doubtful when I put the defect device, but thanks God, Alhamdulillah, we can put it very easy, and the position with the confirmed with the fluoroscopy was called the burger sign. The burger sign is very nice position. So sorry, I cannot put from the SVC because it's quite difficult to cross the ASD. So Dr. Siska, maybe when you sometimes, yeah, our marshal cannot show us anything. If the marshal cannot show anything within 15 minutes, so I have to change the fluoroscope.
Yes,
Okay,
this
thank
is
you.
the importance of the master area. We
Yeah.
can't work without a good master.
Yeah.
Okay, Dr. Jen, can you answer Dr. Siska question? And I believe that Philippines has more than 100 million population, though, so will be many ISD cases here. But in Philippine Heart Center, the transcatheter closure of ASD is still limited numbers. Is that because there are many other centers in your country who do perform this procedure, or because your doctors prefer to do surgical closure of ASD?
Uh, to answer the question, Dr. Ana, Philippine Heart Center was basically the referring center for all both surgical and interventional procedures. But the program of the hospital was to create also satellite hospital like Philippine Heart Center in different provinces. So the role of the Heart Center team is to teach uh, newly graduate fellows to this satellite heart center in different provinces. So basically, the heart center now is a referring center for difficult cases. So definitely, there are more intervention now as compared 10 years ago. So I was a fellow at that time, 10 years ago, when we begged the surgeon people to give us PDA and ASD. Now they are begging now for PDA cases and ASD. It turns 360 degrees the situation now. So previously we are asking for the cases. Now they are asking for the cases now for intervention. So to answer the question of Dr. Siska, so I have Dr. Radicho has more patients than me. So I usually convert. So um, uh, we prefer in our institution right now is much more for safety of the patient, that if we're not, because we don't need a referral to surgery. They will question eventually our, so we prevent those unfamiliar referrals. So you will become a talk of the town like that in surgery. So we usually dealt with our problems, like if we have embolization, we do the retrieval before referring it to surgery. Probably we've tried already for 4 to 6 hours, then we refer it to surgery. So but it seldom happens. So answering back again to your previous question, Dr. Siska. So um, we are in a toddler event for uh, non-fluoro. So we started only 2019. So ASD, then we're starting slowly with different cases of PDA. We never tried VSD because our fluoro time for VSD is only 5 minutes. So we're only um we would not want the patient to underwent in the cath lab for more than 30 minutes to 1 hour because of my experience of possible complications like stroke, prolonged heparin use. So that's what we avoid. So, but the answer also is that different operators, different institution, different techniques would prefer differently. So if we have much more time, uh, that's the reason why we invited Dr. Radityo in our place, because we need to open some ideas for for some operators to basically take a look at this type of technique, that there is a technique that is zero fluoroscopy that we can be able to give to our patients. Right now, the length of time of the operator with regards to fluoro and non-fluoro is the non-fluoro or TE technique is much more longer compared to the fluoro if you see our previous research. So probably if we're more doing that type of procedure, we'll be able to shift the trend that there will be a shorter non-fluoro time for the patients.
Yeah. I think, do you have any other question, Dr. Riofi and Dr. Siska? If not, because there are some question from the audience, Dr. Radit maybe wants to answer the question. Can you read the question?
Yes, yes, yes. Yeah, I think so. First, why we changed to zero fluoroscopy? Because the real time image is much better, but the position, the whole idea, usually we change. We are looking to the fluoroscopy, so the tip of wire and the direction. So we have to change our mind. And if it cannot be worked, and I think we have to change to classical fluoroscopy. But usually, if we are familiar with those procedures, it's much easier to cross. For Dr. Filari, for instance, how to cross the VSD. Sometimes the angle is less than 90 degrees. So even with the fluoroscopy, it's difficult to cross. So last case, I used the left internal mammary, and then it's still difficult to cross. So I asked Dr. Aryo to guide what's the exact hole and what's the exact direction. Once it's directed there, it's very easy, and so finish. so yeah, it's about the patient. You can see how to cross it. Just put the catheter on the aortic arc and I put push and pull, push and pull, push. Sometimes, yeah, it works in a couple of seconds, but eventually cannot cross again.
Sometimes the defect is between the aorta and the PA, so it's difficult to see sometimes,
Yeah.
right?
Yes. If the angle is too low, less than 90 degrees, and like a crescent VSD,
Correct. Yes.
yeah, it's tough also.
Yeah.
Yeah.
In the last year, 2025, how many percent of your cases were performed zero fluoroscopy compared to with fluoroscopy, Dr. Aditya? What is the percentage ratio?
Yeah, for the ASD is nearly 100%, Dr. Anna. PDA also is a high because it's easy to cross. But in VSD, it's around 70% because the difficulty of crossing, if the angle is more than 90%, 90 degrees, so it's easy to cross. And the procedural time are also less than 30 minutes, Dr. Villarreal. So it depends on the shape of the VSD.
Correct.
Yeah.
Yeah. In your last report in the journal, I think it is in Frontiers, yeah, in 2025, last year. You mentioned there that the size of the ASD is not more than 30 millimeters. Yeah. My question is there any limit on the size of ASD? Because I read also one of our colleagues in Malang, Dr. Henny and team, perform ASD non-fluoroscopy procedure in a huge ASD size, almost 40, I think. That's more than 34 cases here. It was reported 4 cases, more than 30, and the biggest was 40 millimeters. What is your comment on this? Because one of the audience also asked about uh, the limitation of non-fluoroscopy.
Yes, Dr. Anna, thank you for the question. So the ideal is not too big, the ASD, but we also put the big device on the large ASD, and that's a subset of the complex ASD. That's not published yet. The registry is still running, and since we don't have the exact nice device for the big ASD. Some device is limited, and also the stiffness of the device is also have another issue for having the closing the big device. So says the limitation, Dr. Anna. So basically we could close the ASD. If the criteria is included, but we need some extra effort to do for the complex ASD, including very large ASD, and some device with the more than 42 millimeters is very stiff.
Yeah.
Maybe Dr. Villarreal also have some experience with the memo part device. It's very stiff or on the very large diameter.
The largest ASD the occluder we use is 42, but the size is
Yeah.
36 or 3.6 centimeter. But these are for larger person. Remember, the bigger the ASD, the lesser the rim. So, in our data, as the ASD become larger, the rim decreases. So there are only few patients that have good dreams with larger defect. So these are good candidates for transcatheter ASD closure.
Dr. Aditya, since you mentioned that almost 100% of the ASD device closure in our National Cardiovascular Center perform with non-fluoroscopy, then your fellow will learn about a non-fluoroscopy procedure prior to fluoroscopy. What is your comment? Because Dr. Indra Pratama is asking if we would like to do a transcatheter closure of ASD, is that wise to start with non-fluoroscopy? Yeah.
Yeah. The low risk case selection approach for the zero fluoroscopy technique is first the Marshaller. So we have to know that our Marshaller is being able to visualize those cases. Secondly, we are selecting the ideal ASD. ideal secondum ASD that can be closed by the transcatheter. So that's the really starting point. But if the marshaller cannot be able to see the defect nicely, so before here, Dr. Villarreal, we usually put scattered data. Maybe Dr. Aryo can explain. Usually we put only scattered data for the ASD. Nowadays we sweeping all the rims as the marshaller group is assessing the ASD. That's why at that time is many cases that we have failed to close, or the adjustment of the size is not good. So
Correct.
some can be embolized. So
The same.
after that we sweep all the rims and also analyze also the different height, different alignment. So we are preparing the strategy so the complication can be minimized.
Yes. The same, Dr. Radit.
Yeah, thank you, Dr. Mira.
Yeah. There is also a question from Dr. Nadia. Yeah. After the final deployment and removal of the balloon, are there any specific TEE sign of device tension that we should look for to predict the risk of late erosion or displacement in fluoroscopy setting? Maybe you can answer this question, Dr. Raditya and Dr. Jain, based on your experience.
Cardiac
Can you
erosion has nothing to do with the technique, but rather it's the size of the device. They say that in the study in Japan, they have erosions with their previous devices for oversizing those with absence aortic rim. But in our because when we started ASD closure, we didn't start with Amplat's device, so we started with LifeTech. So more than 10 years from now, we haven't had any reported cases of cardiac erosion. So it might be the type of the device and even the measurement, or how did they uh, under oversize the device with regards to the defect. So that's my conclusion. So that's the reason why we have no presently we have no cardiac erosion at this time.
Yeah, I think the same results also here. Previously, we used the blaster device, but when I am working in cath lab, mostly we use the Chinese device, and since then we don't have any report for the erosion. So we are learning with a device abroad, but here from here's my under my commission the cath lab is since 2015. So now we don't have any such as erosion in our cases. Also for the VSD, touching the valves. Yes, so there's no deterioration or also some additional regurgitation in our cases. Thank you.
Yeah, Dr. Aryo, there is a question from the Dr. Brian, I think. When image quality becomes suboptimal, for instance, limited IC window or or unstable mapping, what is the most effective device pathway? Optimize the current modality or switch imaging or convert to fluoroscopy? What do you suggest to the operator, Dr. Ariel?
Yeah, thank you, Ran. So I think the first, of course, to try to optimize the images by all means. So we need to try several views, several angles, and we need to try some other maneuvers. Maybe we need to do some anti-flexion, and and uh, and in those patients with intubated patients, we have to remember that sometimes when there's too much air in the esophagus, and then we need to do some suction to make the images more clear. So there's another tips and tricks to optimize the images. Whenever it's the images is still not that good. So yeah, I think we have to suggest to the operator that we have to switch to the fluoroscopy maybe. So or else maybe if there's any chance that we change to transthoracic maybe if it is more clear, and then we change to transthoracic if it's able to provide better images.
So it is very important to train fellow in echo to this be a good marksman. Yes. So, Dr. Aditya, you use a lot of Sarah device ASD closer, maybe 70 or 60 or 70% of the device which you use. Is there a particular reason for this?
Yeah, because the availability of the device and also the stiffness, the profile of the Sera device is, compared to available devices, okay. So also we can put in the small children compared to the another stiffer device.
Yeah, in Philippines, compared to surgical costs, is device closer catheter is cheaper or more expensive, Dr. Jen?
Almost the same, Dr. Anna. So, it amounted to about 450,000 to 500,000 pesos. So it's about uh,
How many US dollar is that?
almost 9,000 to 10,000 US dollar.
Mm.
Yes.
We
Yeah.
also prefer Seraflex, just like Dr. Radicho. I think the different products we showed in the masterclass is definitely superior. The LifeTech is much more superior than compared to other. So probably that's the reason why Dr. Radicho also likes Sera.
Yeah. Dr. Aditya, if you are very convinced with this procedure, non-fluoroscopy procedure in ASD closer, is that a possibility that this procedure can be done in ICU? So we can
Yes,
see it.
yes. If the equipment
I'm
is there.
dreaming that you will do that.
I thought Rana would stay to do it at the ambulatory clinic.
Yeah, it can be, as Dr. Xiang Bingpan can do in the ambulance,
Oh,
mobile ambulance.
Oh yeah? Oh,
Yeah,
that's great.
I just heard.
So you can go around the district in West Java with the ambulance, cath lab, ambulance, and then do it non-fluoroscopy procedure. The ASD closer in many districts. Wow, that's
yeah.
interesting. Dr. Yofi or Dr. Siska, do you have any comment or question?
Dr. Anna, maybe about the cases from Dr. Jan about the heart block, total heart block after with the closure. In your experience or your opinions, I mean, how should how long that we should wait for this so we can sure that there's not a reversible of the block.
That's a good question, Dr. Yobi. That's also the question we're asking to ourselves, because that was the first heart block that we have experience for ASD. We have not encountered even in PDA and even in VSD. So this is the first complete heart block in ASD closure. So if you read the journals and manuscripts, they're suggesting about 7 days to 14 days, the waiting period. So during the fifth day, we're contemplating to convert it to retrieve or even or ano. So but we waited. Then at seventh day it convert to sinus. So this is our first time that it converted to sinus really. So
So
but
what do you think?
we don't know the long term. It might come back after 6 months, so we don't know. So we're just close monitoring the patient because this is the first time.
Okay, so what do you think that maybe the oversized device or something?
That's a good question also. So we don't know if it's oversized, and that there are so many questions that we're asking ourselves. If we retrieve it and we change it with a smaller device, will it stop the heart block? So we don't know the answer also. So if we retrieve it and refer it to surgery, will it also stop the heart block? So we gave the question to the parents, and the parents answered us with a conservative medical management. So based on also in different research and manuscript, so conservatively you can give the patients through IV steroid, then that's the probably what we decided and pushed through with the decision.
Okay, because I think we also have that kind of case about 2 months ago.
Yes, yeah.
At that time, maybe we do not agree about the size of the device. So we think that the a little bit oversized of the device, and then patient got a heart block, and I think we have to remove it by surgery. Yeah.
Yes,
So
remove
what
and
happened?
also
When you remove it,
use
No,
did it
no,
use
no. We retract the device, and
and
then more
then
than
PPM
two
also.
weeks is
Yeah.
still
It's still,
the
yeah,
heart
did
rate
not
for
PPM
convert
steroid.
and
to
also
the
close
sinus.
it surgically, right?
Mm.
Yes,
Yeah.
and after surgery, it's not even come back again.
It's not come back actually. It's not return.
Have to
Yes.
put the pacemaker.
Yes, because there's no assurance.
Yeah.
There's you cannot give assurance to the patient because this condition happens very rarely. So even our electrophysiologist was amazed that it caused a heart block for that type of situation. So
Yeah.
Yeah. Dr.
One
Aditya,
more question about
uh,
Dr. Anna.
yes, please,
So
please.
maybe your experience, Dr. Johan, about the erosion. Do you agree that the aortic rims would have a higher risk of erosions?
yeah, I think so. Depending on the position of the tip of the LA rim and the RA rim, if it is pushing the aorta, because there's where the transverse sinus
Yes.
is. So if it basically uh, uh, puncturing the aorta, it eventually cause erosion. But if the position of the LA rim and aorta is like this one, like a Pac-Man style, it might not than this one. And the device also matters if it's very hard, so it will cause basically cardiac erosion.
Yeah. Yeah. Because almost our cases do not have aortic rims.
Yeah.
Okay.
Almost
Yeah.
Asian, no aortic rim, right?
Yeah.
Mm.
In our center, general anesthesia was used to all the patient and the patient intubated. Is that right? Dr. Yofi?
Yes, yeah.
Yes.
Today. Yeah.
I
Because
think in Philippines also, but sometimes Dr. Villarreal only have deep sedation, yeah, right, Dr. Villarreal?
yeah, many many centers use just deep sedation without intubated patient. That's why to make it simple and possibility of a mobile transcatheter ASD so then maybe we should go to that procedure. And in terms of cost, of course, it will reduce the cost. Dr. Aditya, when you use fenestrated ASD closure,
Yeah, well, when I find the RR ratio is around 0.33 until 0.5. So we decided to put a fenestrated device instead of fully closed.
and during the follow-up, do you realize that the pulmonary vascular resistance decreasing or static?
No, the follow-up, there's pulmonary vascular resistance still there, but the functional class is really getting better. But the hemodynamic position is still there.
Dr. Jen, do you always perform catheterization before you do transcatheter closure, or you rely on your echo and then straightforward to close the ASD?
We rely on the echo, but of course we rely also on our PE. If the echo saying that it's mild PA pressure, but the clinical condition of the patients tells different, so we do right side heart catheterization. But these are rarely happen. Usually it's we basically believes with our echocardiographer what they are saying. So that's it. If we think it's hypertensive, then we go for a full cardiac cath hemodynamic study.
In some cases, we found, especially in adult cases, the left ventricle is so small and squeezed. In such case, do you prefer to give a device with the perforated or just totally closed? Do you have experience in such case?
What condition, Dr. Anna? Where the LV is smaller than the RV? It's an ASD?
Yes. Sometimes the LV is so small. That's in a very ill patient with the ASD and right heart failure, and then we can see that the left ventricle is so small. Even during procedure, usually we in ICU got problems in ICU.
Actually, those type
Yeah,
of patients are very high risk because you may be able to uh, give what's that? It can cause when you cardiac cut those patients may cause arrhythmia for this type of patients, and this type of patient may have high pulmonary vascular resistance. So sometimes we do hemodynamic study just to tell the patients that it's really for medical management and we cannot do something about it.
how about you, Dr. Raditya? Do you have experience with such case? Do you prefer to make a hole in the device or just close it totally?
I think he's on phone.
Oh, sorry.
Yeah, yeah.
Well, I think it's time is up here. Unless there is another question or comment from Dr. Yovi or Dr. Siska, I will finishing this session. Is there any?
There's no question anymore from me, Dr. Anna.
So everything is clear.
Yes, yes, for me. Thank you so much for all the
It's
speakers.
very interesting, Dr. Jen, to have you this evening. I hope this collaboration between us will be continue in the future, and we can discuss.
I will be, Dr. Jan. Thank you very much.
Thank you very much also for the
Send the regards to Dr. Baby and also Dr. Reganian and all the
thank you.
team in Philippine Heart Center.
Yeah. See you on June.
Yeah.
Yeah. Don't forget
Thank
to
you very
come.
much.
Yeah. I think I
Can we
will
take a
conclude.
picture, please? Can we take a
Yeah.
picture?
Yeah, to all the doctors and participants, please do not leave the meeting so we can have a session to capture our picture together. Please turn on your camera. Okay, in 3, 1, 2, 3. And one more. 1, 2, 3. Okay, Doc.
Thank you once
Okay,
again
thank
to
you very much.
Dr.
Thank you, Dr.
Radityo,
Anna.
Dr.
Of
Jane,
course,
and
Thank you,
Dr.
everybody. Aryo,
Thank you.
Dr. Jan.
Thank
Aryo,
you.
Maraming
Thank you so much.
Thank
salamat.
you, Jane.
and
Thank you, Anna.
also to the audience especially. Thank you.
To all the participants, before we conclude, allow us to introduce an upcoming important scientific event. We are pleased to invite all of the participants to the 6th Indonesian Congenital Heart Disease 2026, which will be held at the Trans Resorts Bali, Indonesia from June 17 to 20. And this meeting will serve as a platform to share knowledge, foster collaboration, and advance the care for congenital heart disease. We are also very excited to share that we offer a special promotion and national moments such as National Awakening Day, Idul Adha, as well as weekly Instagram quiz where participants can engage, test their knowledge, and win interesting prizes. So do not forget to follow our social media platforms and stay tuned for our exciting opportunities. To close today's pre-event webinar, we would like to show you some videos about Indonesian Congenital Heart Disease 2026. Thank you so much to the speakers and also to Dr. Ana Ulfa.
Thank you, Zarina, for managing the time of this webinar to make it very strict on time. Thank you. Bye-bye.
Bye.
Thank
Thank
you,
you.
Dr.
Bye.